So I'm going to talk about the latest treatments for melanoma. This is kind of an overview. So in 20 minutes. So we'll see what we can do here. Okay. Okay, these are my disclosures. Recognizing that a lot of the research that we do, we partner with industry. So acknowledging that. Okay, so I don't think it's an overstatement to say that more things have changed in melanoma in the last 10 years than really in any other cancer. And particularly even in the last 2 years, a lot has changed, mostly all for the good. I say mostly only because now that we have new data, it's just become a more complicated discussion about what we should do with all these different options, like what's the best thing for anyone. I just highlighted some of the stuff here that I'm not going to talk about in detail, but acknowledging that. So one is staging. So we've completely revamped the staging. So staging, as you may know, is the way we identify the risk of the cancer in melanoma. So there's stage 1, 2, 3, and 4, particularly the changing in stage 3, so 3A, B, C, and D. So all of these things are kind of moving parts, but it complicates the discussion when we talk about what additional treatment we should do beyond that. For people who've had melanoma travel to a lymph node, you've heard of probably sentinel lymph node biopsy. So if a lymph node's involved, should you do a complete lymph node dissection? So there's new data from a large trial in the last couple of years that showed that you may not need to have a complete lymph node dissection. So that's changed practice. And then adjuvant therapy. Adjuvant means treatment after surgery. So should you do something to go through the rest of the body, say, hey, I have a stage 3, whatever, I have a certain risk and there's still something there. Can we do something in addition to that? And so that's what adjuvant therapy is. I'm not going to get to dive into that too much either, but I've given actually a few talks in the last couple of months, and it's such a complicated topic, didn't go so well, but we can certainly answer questions about that in attempt to. Some of that, though, is because the data is so immature, but we're excited about a lot of these new treatments, and so we feel like we want and need to do something. And then systemic therapy just means, again, it's the same kind of therapy, most of it for adjuvant therapy, but it's treating for more advanced disease that we're trying to get rid of whatever's we know is there. So we're going to talk mostly about that. I did want to just talk in general about how we make the biggest impact on cancer in general, and then specifically in melanoma, which is really this kind of paradigm of we have to address it in all ways. So really, starting from the left here is prevention. So a lot of my actually research when I first started was in prevention, like preventing it from even happening in the first place, or chemoprevention specifically, the work that I was doing, like doing something to reverse the process of heading into cancer before it even gets there. And probably, although it's not really represented here, it probably could have the biggest impact in cancer. The challenge is how you study that. We know in a lab like how things can happen, but actually we don't really know what causes a lot of cancer. Melanoma is just a little bit unique, and the vast majority of melanomas, not all, are related to UV, some UV exposure. But how much UV exposure, what period in your life you get that, we really don't know. And so it's very difficult to have an intervention and test that to prove that. And then indoor tanning, I thought Sam might talk about that a little bit, but indoor tanning is now, certainly in observational studies, epidemiologic studies, it's shown that there's an increased risk, a 2 to 3-fold increased risk of particularly young people with doing indoor tanning. And so there's kind of a push led by AIM really to ban indoor tanning in minors. Then there's early detection. Early detection is another big piece, and a lot of the screening tests that we do, colonoscopies, mammograms, even CTs of the chest for lung cancer, are of interest to identify something early. For the most part, if you do catch it early, there's a lower chance that it had spread and potentially cure. In melanoma, we study that. It's been very difficult, again, like maybe screening a certain population at high risk to see should you do full skin exams. Has not been proven. However, it certainly makes sense to do it for people who are at high risk. Actually, if you've had a melanoma, that's the number one risk factor for for melanomas, having a personal history of that, and it makes sense. The skin is the most accessible organ of your body, and so it's very easy to do. There's no reason that you shouldn't be doing self-exams and having your doctor do a full skin exam. Can you imagine? You can't see the top of your head and your back, and those are things that other people would have to help with. And then there's treatment. And a lot of the research we talk about is almost, the vast majority of it is in treatment. I think that has the biggest impact. When you think about prevention, like why don't we do that? Well, it's really hard as a human to think like, oh, let me look into the future. I'm going to get that cancer. You think you might never get that. And so to change your behavior is very difficult. But when you're faced with something right in front of you to say, hey, this is life-threatening, I need to do something about that, I think a lot of the work has gone into the treatment. And so this is where a lot of the things have changed pretty markedly. So some of the treatments that I'm saying here are surgery and radiation therapy, which Dr. Kim will talk about, and as a concept, chemotherapy. In melanoma, and we'll talk about details of, and why that's a little bit different in melanoma, but the treatment as a concept is evolving. So now that we have some better therapies, one of the questions is, when should we do that? Should we do that, just do surgery and then do therapy, or wait till it spreads, or actually do it when it's kind of before you even do surgery? So all of these things are evolving in questions, and they make a lot of sense. So it's again, the adjuvant therapy, although was kind of pushed along to the right, is now kind of stretching out. Again, not a simple conversation, but all of those things are mostly for the good as far as how people can do. Okay, but cancer therapy is in its adolescence. So the treatments that we've done in the past with surgery, radiation, hormonal therapies, they've all individually have done a fantastic job in a subset of patients. But when we think about the cancer problem kind of broadly, we have a lot of work to do. One of those, or two of those approaches with immunotherapy and this kind of genetically based or targeted therapy is starting to transform the field, and we're starting to see some growth. So we're very excited about that, and particularly in melanoma. Actually, melanoma, oddly, I mean, as you all know, went from one of the worst cancers, but we now with these two kind of broad categories, really has kind of led the field in these two approaches with the different immune therapies and the genetic-based therapies, particularly BRAF type therapies. So I'm going to talk a little bit about cancer. The history of cancer immunotherapy is fascinating. Actually, Dr. Cooley, back in the late 1800s, had noticed that there was a subset of patients who had developed infections, and there was a subset that actually had some regression of their tumor. And so he, of course, you could do anything you wanted back in probably in the 1800s, started to inject tumors with a certain type of bacteria. And there was a certain percentage of tumors that actually shrunk. And so he published our first publication of cancer immunotherapy in 1893. Subsequently treated hundreds of patients because unfortunately then, again, surgery was the only option. So for inoperable tumors, this was the approach. And he had a 10% cure rate. I don't know what that means back then, but certainly a response to some kind of benefit in a subset of patients. They thought it was the bacteria that was doing it. In the end, it's likely the immunologic effects that come from that actually has shown regression of the tumor. Okay, so I've given a lot of talks. I remember even at AIM, the first one, I said, you know what, I'm going to talk about these genetic therapies, and I'm going to explain it so all patients will understand. It's a complex story. I thought I did a great job. Afterwards, I asked people, how did it go? They're like, I had no idea what you said. So then we get into immune therapy. And I was talking to a colleague, I said, how do you explain immune therapy to patients? You need immunologists, people really like your talks. And so he goes, I'll send you a slide. And so the slide is this. He goes, there's immunotherapy. And everybody liked that. Okay, obviously not so simple. And I apologize for this. It's a very busy slide, maybe intentionally. You can blur your eyes a little bit. So it's a very complex system. Right? And it's a normal process in your body, and yet it's gone awry or the cancers are avoiding it. So how do you manipulate that? But you need your immune system to identify tumor. You need to stimulate the T cells or cells that would fight that off. You need to have chemicals that actually recruit other cells to come. You need to traffic into tumors. You need to have the environment kind of shut down to allow the T cells to work. All of that stuff, fascinatingly, the tumors can avoid in many situations. But the primary area that's been, or at least the most really transformative part, is this concept of checkpoint inhibitors, or this blockade of tumors for your immune response. And so the cancers have developed an ability to block that tumor, and some of those pathways and mechanisms are through CTLA4, which you may have heard of, and PD-1 or PD-L1. So as you can imagine, antibodies could be developed against these. So the PD-1 and CTLA4, again, kind of shut it down. But antibodies have been developed to block that and allow the T cells to remain active. So it's blocking the block or inhibiting the checkpoint. So again, allowing your T cells to kind of remain active. And I was told never to show a curve, but I'm showing a curve. Okay, so the point is, This is the first agent that ever had shown improvement in survival in a trial in melanoma. So this is ipilimumab, which is a CTLA-4 inhibitor. I actually had other slides of IL-2, which wasn't as good, but had the same characteristic to it. And you may have heard me talk about this before, but it's this kind of tail of the curve, which is a characteristic of immunotherapy, which is it doesn't work for everybody, but when it works, it could eliminate the disease, and it appears to be gone for many years. I believe people are being cured. Who is being cured? I don't know. Is it going to continue on? I don't know. We don't have the long-term data yet, but we have over 10-year data now for ipilimumab. We have over 20-year data for IL-2. You know, IL-2 is not that often, 3-4% of people. But I have patients, I didn't see anyone in the room today because they're off living life. But I saw someone this week who had no disease from over 8-9 years ago from IL-2. It just didn't work that often. This is just a higher percentage of patients who are benefiting from it. And since then, it's been a multitude of things, not only in melanoma, but in other things, really transforming the field. So ipilimumab or Yervoy, nivolumab, Opdivo, pembrolizumab, Keytruda. There's other ones that have been studied in other cancers actually that we treat, like Merkel cell carcinoma, but in lung cancer and bladder cancer and Hodgkin's, certain types of colon cancer, cervix cancer. So all of these things have actually shown the benefit. And it seems to have the similar characteristic. Like if you have a dramatic response or a complete response, like it disappears, it seems to have a chance that that's going to be gone, or at least be gone for years. And again, we're saying possibly just because we haven't followed people for 20 years yet. These are just being developed in the last 5 to 10 years. So very exciting. You probably know this story. Jimmy Carter had melanoma. He had melanoma in his liver and in his brain. In 2015, he said he thought he had weeks to live. Actually, when I remember, I think my daughter was asking me about that. I said, I think he's going to do just fine. Because we just started we were testing these things. They did radiation actually to his brain, again, which Dr. Kim will talk about, and he got pembrolizumab. In 2019, he was living his life, probably building a house somewhere, and fell. And he's like, I just didn't think I would be here. So, but he's doing the things that he has wanted to do. Very peaceful with his life, but really, I still think quite fortunate that he's been able to benefit from these things at 95 or so years old. And excitingly, another point is that this is a 91-year-old who was actually a candidate for these therapies because, for the most part, a lot of people do tolerate that, at least the single drug, fairly well. Okay, another curve. I have one other one. I apologize, but I'm going to. So the point of this is this IL-2 here, not great, but the same characteristic. Ipilimumab, the new data, new characteristic. Pembrolizumab and nivolumab, it's bumping the curve up and up and up, right? So now with the combination. Obviously, we have a little work to do here still, or a lot of work to do for a number of patients, and also the same concept of for other cancers. So melanoma is a little bit more, or a lot more sensitive to the, manipulating the immune system, where a lot of other cancers don't. And so, but the same strategies that we're trying to overcome people who aren't responding in melanoma is the same with other cancers. And hopefully, again, as we go up, that ultimately 100% of people will benefit from that. And that is blue intentionally. This is actually profound enough and important enough that the Nobel Prize actually was awarded to Dr. Jim Allison, who discovered CTLA-4, and Dr. Hanjo, who discovered PD-1. Many, many, many other people have contributed to the work beyond that actually to result in it, but well-deserved Nobel Prize in Physiology or Medicine in 2018. Okay, not without risk, right? Some of you may have experienced this or have heard about that. So we're trying to manipulate the immune system to attack the melanoma and whatever cancer. The unfortunate thing is that same immune system can attack your normal body. And unfortunately, it can attack any part of your body. Sometimes mild, but sometimes could be quite severe and even life-threatening. I put on here itis, which is just inflammation of pick a body part. So Dr. Bishu is going to talk about some inflammation in the gut, or colitis, hepatitis, inflammation of your liver, pneumonitis. Again, pick a body part. If a patient is going to talk a little bit about that inflammation of this kind of unusual hormone gland, which really can affect your life. Some of that stuff is permanent. Some of that stuff is reversible. But it absolutely must be balanced, these side effects, with the potential benefit. Obviously, we're saying, hey, this could be great, but and Jimmy Carter could get it, but it can come at some significant risk. This is also, I think, very important when we're talking about pushing the treatments into this so-called adjuvant space, meaning like you don't even have cancer right now. You have a risk of cancer, but you should do this therapy because it can help you X amount. When we don't really even know what that amount is, and this could wreak a little havoc on your body. So this is part of my discussion when I've tried to lecture on this before about the types of treatment. It's completely different immune therapy, but all of these factors have to be factored in to be able to make a discussion what's best for you. Obviously, if you have stage 4 melanoma or any cancer spread, you don't have much choice. I mean, these are the things that we have to kind of deal with, but we do our best to try to minimize that. And one is the fantastic staff, and really I believe to be probably the experts in our nursing staff who are able to help people and support people through that, and fantastic colleagues who actually help with that. This is critical, really, kind of a multidisciplinary approach. Okay, what time we got? Okay, I said I tried to explain this genetic thing, and I was going to do something simple, and here we go with a more complicated slide. Okay, so what is BRAF? You may have heard of that. So this is one of the genes. This is specific and also as a concept of a targeted or an actionable mutation, like a gene that you can go after. So genes, as you may know, code your body, right? So we look for gene mutations or an abnormality. So BRAF happens to be a gene that's mutated or abnormal in a decent percentage of patients with melanoma. So this is in the melanoma. It's not an inherited mutation that you pass on. But what it does is just like a switch. It just turns the cell on. And so this is what we call a signaling pathway. So each cell actually fires down and it tells it, in a sense, what to do or grow. But when it's mutated, it becomes what we call constitutively active, or some people can say that, where it's always on. The switch is always on. It's continuing to kind of stimulate that. Now, in melanoma, you probably need additional injury to that cell to ultimately transform that into a cancer cell. But when that's present, it just drives it, and it grows into a cancer, or allows the cancer to continue to or spread beyond. And this happens, if you get it on a test, about 50%, but it's partly dependent on if you have a mutation, on age. Like younger people tend to have more likely to have that. Older people can absolutely have it, but it's less common. So we test it almost in everybody with advanced disease. So this very, very specific one letter in the entire code is abnormal. So these agents actually have been developed. These are 3 different agents. We call them BRAF inhibitors that can bind actually to this protein that's developed from this gene, and it very, very potently block it. However, the cancer's melanoma specifically can find its way around it, what we call resistance. And so a second set of agents were used in combination. So these are used together, and these are here. So dabrafenib, vemurafenib, and encorafenib, you may know it as Tafinlar, Zelboraf, and Braftovi. I have to think every time. Okay, trametinib is a Mekinist, Kotelic, and Mektovi. Okay, I did it. All right. Most everybody knows them by their trade name. But turns out these agents, when they have a second block to overcome the resistance, pretty consistently actually have a better control of the disease. And you can see a very dramatic response with tumor. This is kind of the obligatory pictures of that. This is real. So this is a PET scan, kind of a snapshot. And most of those black spots are melanoma. And you can see with these BRAF inhibitors, pretty dramatic. I mean, this is really kind of miraculous to seeing melanoma just melting away, even within a week. I mean, it's pretty crazy. But the difference with these is, unfortunately, for some patients, it doesn't last that long, and you can see the resistance develop in that. And so, again, the MEK inhibitors will overcome that. We've done some trials to add a third agent or a different approach, actually, to enhance that as well. So as a concept, immune therapy may not work as often, but when it works, it can be a long-lasting effect. Where the BRAF and MEK inhibitors work frequently, but may not work as long. But there's definitely subsets of patients. This is my last curve. I apologize. So there are a subset of patients, though, with these BRAF mutations and these treatments that do well long term. I know someone who's in the audience with that, which is, I don't know, 8 years ago, and actually off medication too. So I believe there's a subset that are being cured. This is also a similar concept in the adjuvant space. Like, could you, if you have a small amount, could you just get rid of it? So what I wanted to just highlight is this. Again, this is survival. I apologize, but you see that a pretty substantial amount of patients can do well when this is mostly for kind of small volume, if you will. But my point is that if we can figure out who those patients are, they're going to do really well with these agents and have a long-term control of that. It becomes a fantastic option. And again, figuring out why resistance, or adding in another drug, or just picking and choosing who we're going to give these to, you can get the same result. So a lot of the research happening now is like sequencing them, doing them all together, like all of these things kind of working together, or completely new agents. And so new agents being studied. Unfortunately, there's not something like being approved tomorrow. There is an agent called relatlimab, which is in the kind of the final stages, which we're pretty excited about. It's basically another checkpoint, different mechanism. And we're trying to figure out how to combine these things together. Most of these things are very complicated, where we're very collaborative with really folks around the world to try to do all these studies together. I believe all of us are, there's been fantastic people, again, kind of move it forward. And there's multiple other immune modulators. You can remember that blurry picture of all the different approaches to say, how can we improve upon what we're doing so far, is continuing to work. We and others are working on these personalized vaccines. This has also been a strategy that's been looked at for decades now. Like, well, you can stimulate your immune system, but how is it against your specific tumor? So taking out tumors, looking at these little pieces of them, or these peptides. So nowadays, it appears that we can identify these more specifically for that tumor and develop an immune response against that tumor that wasn't otherwise responding, like expand those types of peptides or targets, and then use these agents that we have already to really improve that response. So this is ongoing work, very complicated, very expensive, very demanding. So it's continuing to work. This cancer stem cell, which is one of those concepts was pioneered here. We are continuing to work on strategies with a similar concept to say, hey, if a cancer goes away but comes back, maybe there's stem cells. Now, melanoma may not fit that same model, but we're studying that. And then CAR-T, I'm just saying because this has been really transformative, particularly for certain types of blood cancer. It's been a challenge with solid tumors. It is being studied. But the reason it's exciting is because you can see dramatic results in people who have failed many other therapies. But the challenge partly is trying to get the target right, trying to get it to traffic, trying to expand and overcome resistance. But all of those things are being studied. And then lastly, there are a lot of complications from these things. And, our goal in care is to take good care of people. And so when we give things that cause a lot of problems or don't allow people to continue on treatment, we need to figure out how to get people to be able to tolerate these things, so we can, so the treatment isn't worse than the disease. And so one of our fellows, actually Dr. Mahirs in the audience, is working on a protocol with Novartis with canakinumab, which actually limits fevers and chills. These BRAF inhibitors do have some side effects, particularly fevers and chills, that really prevent people from continuing to take these agents. So this is a trial we're trying to do to help people to be able to continue on their medications at a dose that could be effective. Microbiome is a fascinating area of research that Dr. Bisher, I think, is going to probably touch on. But we believe that actually has a potential impact on immune response as well as toxicities. And we're actually going to have a clinical trial to see if we can kind of reverse that or minimize, again, improve in benefit and minimize toxicities from the treatment. I put on here CBD. This is a little bit of a hot topic or a hot button topic. We are talking to a company now who actually has had a little bit cleaner version of this cannabinoid receptors, which is what those affect. More specifically, not have maybe psychotropic effects or whatever, to help with inflammation in the body. So that's actually really, again, a kind of a fascinating area of research that is just really starting. And then finally, there's a lot of other toxicity too, and I'm acknowledging this. I do not have an answer. But these drugs are incredibly expensive, and this is an interesting study at the University of Colorado, hundreds of billions of dollars for the estimated cost of cancer care. Cancer patients are 2.5 more times likely to file for bankruptcy. These agents are approved, and so a lot of them do get covered, but even the BRAF inhibitors are prescription still, even though it's a treatment for cancer, covered differently. There's sometimes thousands of dollars a month, which is pretty crazy. So just acknowledging the fact that we need to be aware of this, we need to be cognizant of it and continue to think about what we're doing. Again, like being able to treat people, potentially eliminating the disease or curing, but what percentage, at what cost, all of these things have to be factored in. Okay, really my last slide. So any patients of mine probably have heard me say this. So I'm hopeful, but honest. And so when I first kind of start talking about that, so all of these things are the hopeful part, right? So like, hey, more and more people, but acknowledging the fact that not everybody responds to this. Actually, the patient this week said, you know what, I'm not going to come to the talks. And I said, why not? He goes, because I'm not one of them. And it's really hard to hear people talk about how well people are doing when I'm not. Although he might in the future. That's my hopeful part. But it acknowledges the fact that even in the last a couple of years, I've had a number of patients who I became friends with, really, who also were in that small group of people who didn't do well. So our goal, I think all of us are here, specializing in what we do, to continue to kind of move that bar for patients and friends who have not made that, and people who are still kind of undergoing that journey here, who are, again, not quite in that category yet. So that's all. Thank you.